Thanks very much, Dr. Buford. Joe and I are very pleased that you're all here today because we really thought it was a very productive discussion yesterday on the global health transitions, and today we really want to look at the innovative ways that are potential solutions, as Joe mentioned. I have the privilege of introducing Peter Sands, who is the Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. He's been at the Global Fund since last year, and before that he was the group chief executive of Standard Chartered Bank, which gives a whole different dimension to his role as the head of the Global Fund, and a quite fascinating experience to bring to that role. He was before that a research fellow at Harvard University, and he's been very active here at the National Academies of Sciences, Engineering, and Medicine. He chaired their commission on a global health risk framework for the future, and he's an active member of their committee on ensuring access to affordable drugs and the Forum on Microbial Threats, which just had a workshop yesterday and the day before. Peter, Matt McGregor of the Global Fund did a terrific job yesterday in describing the transition plans that the Global Fund has as part of our broad discussion. We're hoping today you can talk to us about multi-sectoral engagement and sustainable solutions to support transitions. So please.
Thank you, Ambassador. One small correction to my bio, which I'll use as an excuse for everything that follows, is that although I was appointed Executive Director of the Global Fund last year, I only took up the role at the beginning of March, so I'm now sort of 3.5 months into the role. When I read the title of this session, Multi-Sectoral Engagement and Sustainability Solutions to Support Transitions, I said, yes, please. We would like those. And so the way I wanted to use this morning session was actually to throw out to you some of the challenges we face in transitions, to invite you as a multi-sectoral group to come up with, I've looked at the agenda, you've got plenty of opportunity later on today to come up with the solutions to the challenges we face. I'll tell you a little bit about the things we are doing, and I'm sure Matt highlighted some of them yesterday. But there is definitely room for more ideas and more solutions, and definitely more multi-sectoral engagement. But I want to start with a little bit of context, because sometimes the discussions about transition have underlying them a kind of, why are we doing this? Why are we transitioning at all, and can't we do it more slowly? And I think it's really important to address that up front. I think everybody would agree that development assistance for health should be focused on the places with the highest burden of disease and the poorest populations and economies, and should not be in rich places with low burdens of disease. Very difficult to disagree with that in a proposition. The question is, where do you draw the line? Inevitably, anywhere you draw the line is going to be a source of controversy. The second point I'd make is that ultimately, and again I think most people would agree, the right sustainable solution for providing health in any country is for it to be provided through domestic resources. Whatever the model is, that it should be a country-owned solution to health services. How do you get there? How do you go from models which are incredibly dependent on external assistance to models which are more domestically owned and financed? Inevitably, that is going to be difficult. And that's my starting point, is that transition is always going to be hard, and it's always going to involve difficult trade-offs and frictions. The other contextual point I'd make, which is specific to the Global Fund, is we are normally the last one standing. The Global Fund has more countries that are eligible for Global Fund support than pretty well any other multilateral or any other bilateral partner. So one of the problems we have in terms of partnership arrangements around transition is all the partners have left. They are no longer there. And that means we face a particular set of challenges when managing transitions. So what are the kinds of things that we need solutions to? As I say, as I go through, I'll comment on some of the things that we are doing. One of them is a very simple one, is that in some countries, the transition is made more difficult and less successful simply because the planning hasn't been adequate enough or early enough. And I think that's a learning we've had, is that you've actually got to start very early because some of the things that need to be done actually take time. They may require legislation, they may require systems, and they require quite skilled planning and integration across different bits of the government. And there's opportunities for external assistance, technical assistance, and so on that can make that better. But the fundamental thing we are doing is we are now talking to countries about transition many, many years before that is actually going to happen. A second, and this is clearly very linked, is that there are often really specific operational service delivery weaknesses that need to be resolved. And they may be in terms of data, they may be in terms of skills in the health service workforce. A classic one that we find is around procurement. When countries transition to purchasing their own drugs as opposed to purchasing them through the Global Fund, us purchasing them for them, we often encounter issues around quality control, around stockouts, or around the price they end up paying. And there's all sorts of different reasons why that can be the case. Sometimes there is, and this is a perfectly legitimate desire to build a local pharmaceutical industry. The problem there is that sometimes that involves buying drugs at a higher price, and sometimes those local pharmaceutical manufacturers aren't operating to international quality standards. This is particularly a problem with TB, because the most reliable way of generating drug-resistant TB is to be providing people with low-quality drugs. We're doing a lot of things around this. One thing I want us to be able to do more of is to be providing access to our pooled purchasing mechanisms, even when countries are paying for drugs themselves. That's a little more complicated than it might seem, because apart from the technological issues around it, you often run into issues around legal barriers to accessing international PPM setups, or barriers around registration of product, and so on. But broadly speaking, there is a whole issue here around procurement capacity and systems. And there is actually remarkably little technical assistance provided to countries on those specific functional skills. I'm conscious that it is something that many private sector companies have deep expertise in. There are also some opportunities here around quality assurance. We are very keen on local manufacturers going through the WHO pre-qual process, because that provides an assurance of quality of drugs. A very different set of issues comes up around neglect of key populations, particularly with HIV and TB. You often have concentrated epidemics, i.e. so the incidence rate across the country as a whole becomes extremely low, but within the MSM, sex worker, drug user, populations, transgender, you will find very concentrated epidemics. And we sometimes find a situation where, frankly, the government just doesn't want to deal with it, and they want to neglect or ignore. And that becomes a fairly testy issue for us. And what it means is actually one of the things we keep doing, sort of as our investment in a particular country is coming down as part of the transition process, one of the last things we're investing in, and things we keep on going, is the investment in services for key populations, and also the investment in the argument about why it is so important to give these key populations access to services. And this is very linked also to the whole set of issues around civil society engagement, because typically the people who are actually delivering services and providing advocacy for these key populations are civil society organizations, and we work very, very closely with them. And when things go wrong in transitions, it's sometimes around the fact that there's an interruption of support to civil society, and civil society can no longer play their role. And so we're very focused on normalizing social contracting. So making it normal for governments to be working through civil society in providing services to these segments of the population. And that has worked really well in some places and is much more difficult in other places. But there's a big sort of human rights aspect to the whole transition challenge. That, I would say, is particularly true of both HIV and TB. We face a somewhat different challenge on malaria transitions, and the malaria transition issue is it's a sort of complacency. It's the classic problem with malaria is you get to a certain stage of prevalence where malaria actually becomes very rare. It's incredibly expensive on a per-case basis to really eradicate malaria, and it's difficult to sustain the political momentum to do so. There are great successes. Paraguay has just been certified as malaria-free, and we have another set of countries that are sort of on their way towards it, but it does require sustained political commitment to take it there. Now, underpinning all these issues, and of course I've been very quiet about this problem, is the problem of money. Because all these things take money, and we are, as part of the transition process, reducing and withdrawing the financial support that we are providing, so somebody else has to step in and do it, and typically that is the government. And we face a couple of issues there. One is they have the money, but they don't want to prioritize it. And that's particularly an issue where key populations are concerned, because they just don't have the kind of political salience and support. And so that's why it's incredibly important to make the human rights arguments, and as I say, to normalize the working with civil society to give access for these populations. The second is, and this is one that I think we typically underestimate, is many countries simply have too narrow a fiscal base that even if they prioritize more, the starting resource envelope just simply isn't big enough. And that means addressing some really fundamental issues about the fiscal sustainability of countries. What do we do about this? Well, we get engaged very early, and typically with all our countries, on co-financing. We typically make 15% of our grant contingent on a co-financing obligation, and we do that with countries that are nowhere near transition, because we want to build in a sense, the habit of paying for elements of the services and the interventions that we're working on. We are also working with a range of partners on things like national health accounts, budgeting systems, how they think about whether it's earmarked taxes or different ways of financing their health system. And so that's working with people like the World Bank and others to do that. But that is a pretty fundamental issue. If the money isn't there, then a lot of these other problems get pretty acute. But actually the most fundamental issue here, I think if we took stock of the ones that have worked well and the ones that haven't worked well, is political will. All these issues are surmountable if you have top people in government who want to solve them. And it's very difficult to solve them from a technical perspective if the top people in the government aren't interested in solving them. It's just very, very difficult to make progress on that. So where does the multisectoral element come in? We at the Global Fund cannot solve all these problems. Right. We don't have the capacity to help every country build procurement capabilities. We can offer access to ours, but we can't build that. We don't have the capability to support every country's efforts to build a more sustainable financing solution for their entire health system. We can do aspects of this thing, but we need to work with others. And as I said, one of our challenges is that for many of the other partners, they've already kind of left or downscaled before we are in that situation. I'm very keen on us working not just with the World Bank, but with the other regional banks, because many times people like the African Development Bank, the Asian Development Bank, EBRD, and so on, are still there in middle-income countries and have capabilities and can do stuff on, how you do effective budgeting, how you do procurement, how you think about the sort of evolution of your tax system to make it more efficient and effective. And so I think we need to step up our engagement with them. The civil society aspect in terms of a multi-sectoral engagement is absolutely critical to what we do, given that the key populations part of the story is so vital. I'm very keen to identify where private sector companies can do more. Some of this is not obviously top of the list for your average private sector company sitting in a middle-income country. For them to get engaged with problems affecting MSM, sex workers, transgender, in drug use, most middle-income companies is not top of their priority list. But how we can get them engaged, particularly around the functional skills like sort of procurement and so on, I think could be very, very helpful. So those are just some of the challenges that we as the Global Fund would love to see others engage with us more on finding the solutions. We are definitely doing the things that are within our control, and we are already engaged, as I say, with not just the governments, but the other multilaterals, civil society, a range of different actors on this. It works. Sometimes it works really, really well. Sometimes it is much more challenging. The nature of the issues are, it's very country specific. If you're operating in a federal environment, it's very different from a unitary state. You often have huge disparities between conditions in the capital city and conditions in other regions. So these issues, there's no sort of cookie cutter answer to them. So that is all I was going to say. I don't know if there's time for questions or how you want to do this, but I'm happy to take some of you if we have time.
Very good, thank you. So we'll open it up to questions.
Thank you so much. I had one follow-up question is the diaspora and thinking about that as a source. Because I know, having worked with Azerbaijan, where the GDP had increased such with Gavi that they were supposed to be paying for their own vaccines, but actually the money wasn't going into the health sector that was coming into the country. And so just your thoughts on how to reach, I know World Bank sort of tracks that information, and just your thoughts on that. Thank you.
It would be great to be able to leverage more out of the diaspora. I do think, however, that I would be focusing interventions focused on diaspora on things that are time-limited interventions. So in countries that are nearing malaria elimination, I could imagine trying to get rich diaspora excited about putting their name to having rid their country of birth from malaria. I am worried about institutionalizing basic services like provision of vaccines to what is inevitably going to be a somewhat erratic income flow. I think we need governments to step up and say, these basics just have to be a fundamental. So I would be focusing on interventions that achieve a time-limited goal. And that's why things like getting to malaria elimination, I think, is something that you could excite a diaspora around. I think another.
Okay. Hi, Amanda Glassman from the Center for Global Development. Thank you, Peter. This is the first time I've heard a head of a global health fund or entity talk with such clarity about transition. So thank you for that clarity of vision. I wanted to ask you about, in that policy dialogue about transition with partner country governments, how are the different global health funds working together to present sort of a timeline and the ask that is being made of governments at any given time? Because one thing that we've been looking at is, Global Polio Eradication Initiative, PEPFAR, Global Fund, Gavi, all have sort of slightly different timelines, IDA. Is there an effort to come as the global health sector together to ministries of finance and sort of give them a heads up on the timing of when these transitions occur, not just in terms of eligibility, not eligibility, but also the money, the co-payment this year goes to 40% instead of 15%. Do you know what's afoot on that?
Not as much as I should be. I can tell you that Gavi and Global Fund communicate very closely on these issues, although Gavi is typically transitioning significantly earlier than we are. But we do communicate a lot around these things. It's much, much harder to do with the bilaterals. And the World Bank has its own kind of metrics and method of doing these things. So it is quite difficult to do in a sort of health sector overall way. And I mean, we do find ourselves in the position where we're kind of the last one standing. I would also say that the issues we face are in some ways quite different. I mean, the issues around key populations and the sort of whole human rights aspect of this is very distinct, say, from the set of issues that Gavi would face on these things. But I think there is a need to have more integrated discussions, and this is something where I think in the context of UN reforms and the increasing role of the UN resident coordinator, there's scope for the UN to play, because it's not just also across the health sector, because you've got transitions in health, in other dimensions, and if you're the finance minister, you're not just interested in the health aspect of it, you're interested in that broader picture. So people like Siddharth, I think you have a very critical role to play in these things.
Hi, Carmen Villar with Merck. Thanks for all your great points this morning, really important. And I think from the private sector perspective, we are, in fact, all of us, trying to plug in where we can bring the most strengths and help in these kinds of transitions. I'm curious for your comments about Richard Horton's opinion piece and how we can dispel better some of the things that were put forward in that Lancet piece recently.
I can't remember which one you're talking about, but anyway, there's enough. I've received more criticism in my few months in the Global Fund for private sector partnerships I wasn't involved in creating than I have for anything else I've done so far. Look, I think we have to accept that the dynamic between the private sector and the global health community is not what it should be, and not what we need it to be. And I think there's probably some blame to be ascribed on both sides of that equation, and we need to make that change. And I don't think that's just a change affecting the private sector of people who produce health products or health services. The thing that really strikes me is how little engagement there is of the private sector that isn't involved directly, because the private sector has a lot at stake in terms of the health of their staff, the health of their customers, the overall vibrancy of the economy. But the contrast I find quite interesting is if you look at the climate change world, if you took the sort of Fortune 500 companies, my guess would be that almost all the Fortune 500 companies have had task forces and teams on climate change, have adapted some of their products, have adapted aspects of their business model, the way they do things, and they've really focused on it and spent time on it. I suspect if you ask that same sample of major companies, how many of you done stuff on global health, and stripping out the ones like Merck, who obviously part of their business, but I mean all the other sorts of companies, very few of them would have done anything. And that's partly because it's a blind spot for the companies, but it's partly also because the global health community hasn't reached out and engaged with them. And I do think we need to engage. And being engaged with the private sector doesn't mean that you're going to be always agreeing, always cuddling up to them. It means you're also going to be challenging them and criticizing, but it's in a context of a dialogue. And I think we are going to need that kind of engagement to be much more pervasive in global health if we want to achieve the objectives of SDG 3, because these are very ambitious, fantastic things to achieve, but they will require the kind of capabilities, the infrastructure, the influencing, the advocacy that the private sector can bring.
One more question? Sid?
Peter, thank you. Great introduction, and congratulations again on your new role. I think what you've said is very, very pertinent. What we need is proof of concept of how public-private partnerships work, and I think what we need to then do is go to scale. I see the role of the global funds together with Gavi being crucial at the country level, partnering up with the UN reform agenda where the H6 partners come together supporting the government in advancing this, because I think we need more private sector into the space, because that's where you will get, foreign direct investment, you get innovation, you get technological prowess, and you get the leapfrogging dimension to it. So we would really welcome more of the Global Fund's leadership at the country level together with the rest of the team to advance this agenda.
Well, thank you. I mean, I can assure you you'll continue to get is the Global Fund engaging with the private sector. And I don't want to suggest that we haven't already. We've got lots of exciting partnerships, and they do bring sort of insights and ways of doing things that I think are extremely helpful. I'll take one small example. We have a project with Nando's in Mozambique. And Nando's, for those of you who aren't familiar with peri peri chicken, is a restaurant chain. And the thing that I thought was interesting about, and yes, they brought money, but the thing that I thought was interesting was their focus on the employment model for people who were doing indoor spraying. And the reality is most people who do indoor spraying are employed on a sort of no career path, no training, no development trajectory basis. It's a horrible job. It's hot. It's smelly. It's a pretty unpleasant job. And the Nando's people said, we should think about this in the same way we think about somebody we've just hired in to wait tables in a restaurant, is that the way they think about it in Nando's is anybody they hire with the belief that that person can end up managing a restaurant and that they can provide them a career trajectory and the training and the opportunities. And of course, not everybody will do that, but it's that every job has a pathway. And so they were sort of looking at this in that kind of way of thinking about it. So the private sector can of course bring all sorts of technological innovation, be it, data systems or drugs or whatever, but it also can bring sort of innovation and ways of doing things around really practical things like how you manage and develop and retain people and get the most out of them. And that I thought was a good example of that kind of value added.
Peter, thank you very much. This was very enlightening, and I know you have a plane to catch, but we really appreciate the fact that you came with us this morning, and let's give him a hand for all that.
Thank you. And when you've come up with the solutions to all those problems, Matt will be very happy to take them. Thank you very much.